And there's so many issues around it that it requires an astute physician with deep thinking to manage it. And it can become difficult to manage such complexity in the type of medicine we have established and how we run our practices, how we teach undergraduates and postgraduates. I think this invitation with obesity is also an invitation to rethink. You know, I remember when I was a medical student, the professors used to say, read Telly O'Connor and read William Osler. Osler used to say, if you know syphilis, you know all of medicine, right? The signs, symptoms, how to think about medicine. I think today that has changed, that if you know obesity, then you know medicine. And how we teach even has to be different in terms of the drivers and causality. So there are issues around the hedonic input as well, and I've mentioned environment already, as you can see on your screen. So it becomes very difficult. And remember, hedonic input is a human trait. Animals tend to be satiated once homeostasis is established, once you're full after eating. But a human has the ability, even when full, to say, I like that experience or the memory of it, and I shall continue eating to relive that experience. Or I like how that made me feel in a certain situation. So when I face that agitation or stress again, I'm going to do the same thing to feel comfortable, you see? So an inability to manage stress, emotions, or to govern this hedonic drive will lead to excessive food intake, and that can be disastrous for your health in the long term. And then activity is also affected by various psychosocial drivers. So the invitation, this picture, just to sum it up, is that as we talk about obesity, we need to think more organically and less mechanically. You can't just replace a spark plug and say, we've sorted the problem. And this, I think, has been the historical problem with treating obesity. Look, there's the other element, that obesity has been treated with a lot of judgment, there's something wrong with you, you need to eat better. It's not as simple as that. I think I've realized that as well, because that part of me was there to some degree as a medical student. Like, I wish people would just eat better. But the empathy has now developed that I understand how human desire works in the mind. And the drivers of that desire are very powerful. And I feel sad if a person's not able to govern that. You've got a very powerful itch, you just have to scratch it. So you become a slave to that desire. And I think part of medicine is us doctors deeply understanding how desire works at the mind level. And if we know how to talk about it and govern it better, then that teaching to patients through development of the intellect becomes very useful in the long term. So, as I was saying, I mean, there's a role of the brain in controlling eating, and there's homeostatic eating where we eat for survival. We have to eat. But then there is the homeostatic eating is driven by various good hormones like GLP-1, which improves satiety or increases satiety. Ghrelin is a hormone that increases hunger. So the balance between these hormones is very important when it comes to appetite. Then you've got the hedonic eating center, that dopamine drive, that opioid or cannabinoid drive. Now, this is liking things. Now, why humans have this hedonic center? You can ask it as a medical question or a philosophical question. If you look at the idea of original sin in the Bible, the Garden of Eden, and the first point of where the mind says, I like to do it my way. There's something there in it that's perhaps philosophical, some form of test. And we should not suppress our hedonic desires, but we should also not overindulge them. It's interesting to note that activities like meditation and yoga activate these receptors quite effectively, some studies have shown. And these patients then don't need hits of external things. So you'll see a lot of mindfulness philosophy coming into obesity and lifestyle disease management lately. But it's important to understand that these drives are very high in obese patients, and we need to be aware of that. And then executive function is the frontal cortex, prefrontal cortex, the forebrain, what I looked at as intellect, logical training, and that can be developed through training, but that's the long haul approach. So if you've got a strong executive function center, The mind may say, I like sugar and I want to eat it today, but executive function will say, maybe not such a good idea, weight is a bit up, risk of diabetes, it's not going to be congruent with your long-term goals. So that hedonic drive can then be knowledged away, not suppressed. But in the absence of a strong executive functioning, this is going to be the driver of behavior, you see? And then we're going to overeat or not exercise. Hedonic driver can also say, I don't want to exercise, I like not to exercise. I want to do what I like and I want to avoid what I dislike. So executive function, very important here. This is part of my interest in terms of education and philosophy, how to develop intellect more. But then here we can think about prescriptions, treatments. Part of the reason we did sugar taxes is to try and jolt the center in the mind to think, hey, this is expensive, maybe I shouldn't have it. But then some pharmacotherapy can also be useful at that level, right? So at the end of the day, what we want to do is develop more sustainable behaviors in controlling eating through both education and pharmacotherapy and other lifestyle interventions. Now, obesity is associated with multiple comorbidities, and I see these patients every day. I had a patient that came all the way from Harrismith to Johannesburg today. He was obese, he had dyslipidemia, he had hypertension, he had gout, he already had osteoarthritis of the knee, right? He had some varicose veins already. He's already pre-diabetic. He's had impaired fasting glucose. He suffers from chronic back pain. He works as a mechanic, right? He snores a lot at night, but hasn't been proven to have sleep apnea yet. So he's also got hypogonadism with low testosterone levels. So these kinds of cases, and it's interesting that the referrals from general practitioners and even physicians sometimes is that we don't see this thing at the center of it is obesity, you see? And we're all treating the patients with statins, with blood. This patient was on 40 milligrams of atorvastatin, was on 3 blood pressure medications. He was on 800 milligrams of Puricos for gout, and yet still had TOFA, you see? The testosterone deficiency was there, but due to affordability and other issues, he didn't take the testosterone replacement therapy. It's probably wise. It's better to try and get the weight down to improve. In women, we see every day patients with PCOS, subfertility, pregnancy complications, knee issues, and then all of these cardiovascular risk factors as well. And then this is a chicken and egg scenario. Depression and anxiety can drive obesity, and then having obesity drives depression and anxiety. So with such a commonly prevalent disease, with all these complications, it's important to understand this root issue, because addressing the root issue can reduce a lot of complications, cost, improve quality of life, burden on healthcare, work, etc. Other important one I think we underestimate is that there's a move to start seeing a lot of the common cancers as diseases of lifestyle. Breast, colorectal, ovarian, pancreatic cancer, etc. are very common cancers we see. And through estrogen dominance and inflammation in the body and hyperinsulinemia, we see a lot of theory on how cancer can develop. But cancer tends to not just spontaneously develop unless it's a very genetic cancer in young patients. There's a long history of a combination of factors that come into play to lead to DNA damage, that the cells proliferate. And what we're seeing is that obesity is a highly toxic inflammatory state with lots of hormones that are being produced that promote growth. I think of it very simply. When you damage cells, they divide to heal. But when we keep damaging cells, they maladapt to just keep healing. And that healing, unstopped, is actually tumor growth at the end of the day. Generally, cancers of adulthood don't occur unless there's areas of constant damage. Lung cancer is smoking, bowel cancer is toxins and unhealthy food. So in the body, we say, well, what toxins are there? Well, this chronic inflammatory state could be something to look at. And there are theories on this developing. I mean, if you read widely, you'll start seeing there's a movement to rethink how we think about cancer. But at the crux of it, I think obesity is a major driver, right? Sorry about that. So just to take you through it then, going further, and then more recently we're realizing that a more acute complication of obesity or risk with obesity is that obesity is a risk factor for severity of COVID. And we have seen it across the board in our ICUs. And even when the second wave came about, people started saying there are patients without risk factors that are getting severe COVID. When I actually examined it, right, maybe the patients were not obese, but most were overweight, or at least carried some significant amount of belly fat. Patients on post-history had very bad diets to begin with. I'm talking about a certain category. I'm not talking about cancer patients and sickle cell disease, etc. But for those that looked to the physician's eyes not having risk factors, when you actually deeply look at it, there were metabolic risk factors in majority of patients, even in the second wave. And obesity around the world has been, if you look at it also, the countries that are called affluent, the first world countries, Europe and America, where they have good economic sort of health, but generally physical health, you see, has been poor. Obesity is very prevalent, diabetes is very prevalent. The rates of obesity, COVID, were much higher, and the severity, and even the UK at one point reached highest death rates in the world per day or per million people. So it's showing that metabolic health plays a role. I've been reading this idea of post-COVID, long COVID, people are talking about. And this morning there was an article from an Australian newspaper where they followed up 3 patients who continue to get symptoms post-COVID. And they're saying, well, we need to look into the science of this more. And they interviewed these patients individually, and I was struck by the pictures of these patients. And once again, without judgment, all of the patients in these pictures were obese. You can clearly see it. And nobody's talking about that perhaps to even improve this long COVID symptomatology after having COVID, we need to look at metabolic health as well. And I think we're going to see a lot of these patterns emerge. These are just my observations so far. And even in South Africa, in hospital mortality, a high number of patients were obese, where there was severe COVID, and then of course the metabolic associations of hypertension and diabetes as well play a role. And then of course the mechanism by which obesity may contribute to severe COVID, there's always theory, remember? And this is at multiple levels. So the obese patient, when they intervene for severe COVID, will not just need ventilation, they'll need special kinds of ventilation. We look at ventilatory dynamics. They'll need to be treated for their comorbidities as well. They may need renal assistance, right? Their underlying metabolic issues need to be treated in ICU very well. If they're diabetic or pre-diabetic, even if they develop dysglycemia, that will need to be treated. So the care of a COVID patient with obesity becomes very complex because there's so many mechanisms by which the severity is enhanced. And then lastly, just to note in this section that obesity does affect life expectancy, and we see this, right? Life expectancy is reduced by 8 to 10 years. It's important to highlight this to patients because people don't do negative things. You don't eat unhealthy to harm yourself. You're eating unhealthy because you want to feel happy. You don't exercise because you're stressed, and you're doing something else to reduce the stress, which will make you happy. So the driver for everything negative is actually the want to be happy. But if you remind patients that this current approach, the want for happiness is not wrong. But I think what we need to examine is our means. And patients ultimately want something in the long term in life, either a happy family or successful job or some career goal. You've got to let them know that the current approach is going to reduce life expectancy. It's very important. So this is why, already the little that I've spoken will highlight that it is difficult to manage a patient with obesity. It's not simple and straightforward. And at the end of it, you must remember the patient and not just, here's a script and go ahead. The script is an important part, and we need to educate them on it. It's very important to understand also that perceptions on obesity change. And if you look at them are different. From a physician perspective and a patient perspective. And I'll refer you to the study in the reference there, the Action IO study, which looked at the perceptions of patients, of the healthcare professionals. The patients actually believe it is their responsibility, but the healthcare practitioner's perception is that patients may not be interested in improving their weight. And then vice versa as well. Where sort of patients may think that healthcare practitioners don't know or may not be interested, but doctors do want to help and are interested. So all these perception issues come to play. And I think the best way to get around that is to have a friendly, invitational approach to talking about a patient's weight. And I always tell my patients, remember, you are not your weight. I said, listen, I need to talk to you about something. It may be uncomfortable at first, but with your permission, I wanted to let you know that weight gain of any kind can reach a point where you can get a lot of issues in terms of the quality of life, and I bring out the slides and show them the complications. Maybe we can talk about addressing the weight, right? And constantly talk about the weight as not you. A human cannot be his weight. Weight is what the body is carrying. I'm a human that needs to look at what the mind is doing so that I can manage this weight better. And that kind of conversation often helps patients. And there's always a delay when patients start experiencing weight issues to the time they have the discussion with their doctors, and I think if we talk about it more medically, it will make them more comfortable and don't feel as much judged. I think these issues are very important to highlight, that it can take time. And it's important to address it early, because if we can get on it, remember I said weight loss takes time. But if we can act on it early, then any weight loss, 5 to 10% weight loss, reduces your risk of diabetes, may even in some cases put pre-diabetes or early diabetes into remission, reduce cardiovascular mortality, improve cholesterol, blood pressure, improve sleep apnea, does even help them function better day to day. There's an improvement in quality of life as well. So I've highlighted why we need to address it as well. Now, why do we need pharmacotherapy? And sometimes people will ask, doctors, even I ask, why do we need to, just throw medication at everything? If the prevalence of obesity was small and we had the structures to deal with the long-term lifestyle stuff, and there was concerted efforts by governments to improve urban environments and all of that, then we can take our time and work with lifestyle. But when you've got literally hundreds of millions of people with obesity within systems that are not going to change, it's a crisis. So just like COVID, when there's a crisis with COVID and people are being admitted in ICUs and overwhelming situations, we need stringent measures, we need laws, we need lockdowns, we need, our rights feel like they're compromised, but not all rights are absolute. And then we need vaccines quickly so that we can buy ourselves time to figure out how we need to make changes so these things don't spread in future, that sort of thing. So similarly with obesity, when it reaches crisis levels, the need for pharmacotherapy becomes more so that we can assist patients to start getting to go and changing this wave that is going in the wrong way. And maintenance of weight loss remains challenging from a personal level and from an environmental level, because you feel initially motivated, but then those physiological drivers which have become maladaptive may cause you to regain the weight through activation of hunger again, or the environment is not conducive with marketing and everything. Patients say, oh man, it's just so easy to get the convenient stuff and cheaper junk food and that sort of thing, or I've had stress. So maintenance of weight loss in the current environment is complex and difficult. And then the metabolic response I've mentioned to weight loss is the body will, the senses will still perceive it as energy loss, energy expenditure. So once you reach the lower end of the thermostat, then drivers come up to increase hunger again in response to weight loss. So what we want to do then is bring in pharmacotherapy to take that maladaptation and reset the thermostat a bit lower. I'm putting it very simply in layman's terms, but just to make the point, So that's very important. And then there is science and theory to show that when we restrict energy, then hormones that affect satiety and leptin, like leptin, etc., will go down. So that will increase hunger again and lead to energy conservation and weight regain. You see? So until recently, the treatment options were very limited, and we had lifestyle management principles which remain the mainstay. Across the board, all patients need to manage lifestyle, and we need to support them with that, with psychologists, dietitians, other interventions. Frequent contact is important, and invite critical thinking and logical thought. Use your slides, use your science to show them how things work. So behavioral modification remains important, but is difficult long term. So pharmacotherapy comes in here. Currently it is indicated for patients with a body mass index of 27 with a risk factor or cardiac risk factor, such as dyslipidemia or hypertension, or for any patient with a BMI over 30. And then of course in the morbid obesity or slightly less with severe complications or with treatment failures, we may consider surgery in the long term. Surgery is complex. You need experienced physicians and surgeons and centers that have done it well. There's obviously a lot of surgical post-op complications to consider. But these patients require a lot of insight, planning, and also a lot of counseling on post-op care, etc. in the long term. Guidelines for the treatment of obesity remain an issue because the various guidelines have various motivations, whether you're trying to improve metabolic profiles, are they pharmacotherapy centric or bariatric, and it depends on the country, the specific needs, the economy of those countries. Canada has very successful, it appears, we've been listening to a lot of doctors from Canada talking about obesity, and they have generally good guidelines which allow for pharmacotherapy, and they consider the patient clinical scenarios in terms of the choice of therapy is very important. But just to highlight that it must be also individualized according to need and availability. So I've highlighted all of this already. I don't want to spend too much time here. I'm going to keep some time at the end for some discussion and questions. So invite patients, ask permission, have an empathetic, logical, but objective. Sometimes you also got to be cruel to be kind. Because if the mind is too overpowering, then patient will, force you. I had a patient the other day who'd been to many doctors, younger, obese. And, I could see she's going to be difficult to manage because her mind is all over the place. So while there's empathy, I also have to be stern with her. And immediately, 2 days after the consult, she emailed to ask and request drugs that are not registered for weight loss in this country at least. And I said immediately, no, we will not go that route. Let's see the psychologist. Let's consider liraglutide 3 milligrams because I think that would be ideal. I know cost is an issue, so let's figure that out. She came from a background where affordability, but then you also go through it with the patient and you say, what are you spending on that is unnecessary? You've got a pack of cigarettes a day, maybe think about that, I can't force you to. So you have to have these conversations with logic and never appear to be judgmental, that can lose the patient. And then bring in the talk around diet, medications, and other issues. And you may need frequent contact with the patient to look at drivers and barriers here, or make some form of access available through virtual consultation or emails or something to that effect, right? So let's get on to the pharmacotherapy now. Liraglutide we are familiar with in this country because, we've been using it as Victoza in type 2 diabetic patients with good effect. And, we know the molecule very well. It's very similar to the human endogenous GLP-1 with 97% homology. It binds well to the GLP-1 receptor and serves as an analog with a half-life of 13 hours. So it's just been modified at 2 points to give it a longer half-life. Human GLP-1 has a half-life of only 2 minutes, degraded by DPP-4. So it's a very nice molecule in that it's similar, which also reduces its side effect profile in terms of skin allergies and stuff, which we've seen with older molecules, which were derived from sort of saliva of Gila monsters and stuff like that. So also good, but the science has evolved to give us something that is very similar to the human molecule. And in animal studies, when you use liraglutide, it does affect food choices. So I'm not going to be talking about the anti-diabetic effects of liraglutide. We're all familiar with that. Just taking you to the new spaces, that when studied for obesity, it does seem to affect food choices. And in these, sort of mice studies or rat studies, the mice seem to choose less candy and more chow. So, and you see this in clinical practice. Patients will say, when I eat that junk food, I don't feel so good, and I want to have less of it. So liraglutide works through those POMC, pro-opiomelanocortin center, and the CART center, cocaine and amphetamine regulated transcript, to increase satiety. Remember, increasing satiety means you feel a feeling of satisfaction and fullness after a meal. And then it also works through neuropeptide Y and a agouti-related peptide to reduce or inhibit hunger. So you can see that on the slide, that inhibitory and green means activates. This all works through the arcuate nucleus in the brain. And there have been very nice sort of visualizations showing the highlighting of the GLP-1 receptors in this area of the brain that suggests that liraglutide crosses the blood-brain barrier at 3 milligrams quite effectively to work on these receptors in the brain. The SCALE program, so we're all familiar with the leader studies using 1.8 milligrams of liraglutide. The SCALE program was the Satiety and Clinical Adiposity Liraglutide Evidence Trial. And this was studying high dose 3 milligrams in patients mainly without diabetes, obesity and pre-diabetes. So this is always an assurance that a large number of patients were studied in various levels through a series of clinical trials, and this showed very good effects. So if you look at the scale of obesity and pre-diabetes, looking at the efficacy and safety of 3 milligrams, and remember in all of these trials, the pharmacotherapy is used as an adjunct to diet and exercise. And this is very important to emphasize, that we don't have some sort of nuclear bomb for obesity here. What we're doing is providing very powerful assistance to what must already be established. And these patients were all obese, over 30 BMI, 27 BMI as well with comorbidities. And you compare liraglutide 3 milligrams to placebo. They included patients without pre-diabetes and patients with pre-diabetes. And the lifestyle interventions there are highlighted. Just to show you patient characteristics, very similar to what we see in clinical practice. And you see over the period of the trials that compared to placebo, the significant weight loss of up to 8%. And the change in body weight from mean baseline, this was liraglutide versus placebo of 9.2% as well, where the mean baseline weight was 106 kilograms. Now, what we also learned, so we know that the pharmacotherapy works to reduce weight significantly. But what we also learned is that patient responses may vary. And this is a regulatory thing abroad, that they say that at 12 weeks, if you haven't lost at least 5% of your initial body weight, to consider discontinuation of the drug. But what we say as clinicians is that individually assess that patient. Are there other factors that have been a barrier to them not losing weight? Most patients, even if they're slow responders, may continue to lose weight. So I think at the 12-week mark, I don't personally use it as an absolute that if they haven't lost 5%, I'm going to stop the drug. But I use it as a reassessment point to consider whether there's barriers or whether to continue. And in a lot of patients, we do still continue and then we see results later. It's just important to remember that there's a concept of early responders and early non-responders. But generally, a lot of patients more will respond to 3 milligrams of liraglutide, right? So that's early responders and early non-responders, right? Now, the categorical weight loss achievers at week 56 still remain higher if you're using liraglutide. So patients with more than 5% body weight loss, 88%, more than 10% body weight loss versus non-responders is 54% and greater than 15%. So the early responder is the person who lost more than 5% body weight at 12 weeks. And their categorical weight loss is high week 56 versus the early non-responder, right? But there's still a continued weight loss which tapers off more quicker in the early non-responder. It just helps you to clinically decide how to manage these patients when you see these differences in the long term. And adverse events were no different to the general use of GLP-1 receptor analogs that we traditionally accustomed to. The most common side effects, and I've seen this in practice as well, being nausea, diarrhea, constipation, vomiting, gastrointestinal. With correct counseling and slow titration, adjustment of diet, generally the patients do well. and we haven't had major issues so far in needing to stop the drug immediately. And if they do vomit at the higher dose or get a bit nauseous, I'll titrate backwards a bit and keep them on the lower dose for longer until they get adjusted, and then go to the next step, you know. So there's always ways around it when we individualize the approach. The scale maintenance program looked at weight maintenance with liraglutide after low-carb diet-induced weight loss. In these patients here, what they did was give the patients a low-carb diet, there's an initial weight loss, and then you put these patients on either liraglutide or placebo and see how they do going long-term. So remember very early I showed you that patients who lose weight through lifestyle modification, they lose weight, but then it starts going up after a while because of these probably physiological barriers and reaching the appetite threshold that pushes weight up again. So in these studies, what you see then is that there's the initial weight loss of 6% with low-carb diet and healthier sort of interventions. And then you put the patients on placebo or liraglutide, and what you see is that the patients on liraglutide continue to lose weight up to another 6.2%, whereas the patients with the low-carb diet will continue, it tends to take off and stay stable. So there's a benefit to the pharmacotherapy at that point at which those very strong physiological mechanisms activate and help bring that appetite threshold down. Okay, and then the slight increase in follow-up later, but overall weight loss established. Now, I have to play a little video here for you, and I hope this is going to play. Let's see if that happens. So I'm going to just switch off my mic for a second. This is about 3 minutes.
Is the only glucagon-like peptide 1 or GLP-1 analog approved for weight management in adults with obesity or who are overweight with one or more weight-related comorbidity, such as hypertension, dyslipidemia, or dysglycemia. Multiple signaling molecules involved in the regulation of appetite and food intake are released from the gastrointestinal tract and brain in response to food intake and fasting conditions. The arcuate nucleus of the hypothalamus contains 2 distinct neuronal populations that play a central role in translating these signals into feelings of satiety or hunger. Hunger is regulated by neurons that produce the neuropeptides AGRP and NPY, while satiety is regulated by neurons that produce the neuropeptides POMC and CART. Glucagon-like peptide 1, or GLP-1, is a physiological regulator of appetite that increases satiety and reduces hunger and food intake. GLP-1 receptors are expressed in several organs, including the brain, pancreas, and gastrointestinal tract. When food is absorbed from the gut, GLP-1 is released, predominantly by intestinal L cells. It is also released from the nucleus of the solitary tract in the brain. GLP-1 is a 31 amino acid peptide. After its release into the circulation, GLP-1 is rapidly degraded by the enzyme DPP-4, resulting in a short half-life of less than 2 minutes. Saxenda is a GLP-1 analog with 97% structural similarity with native human GLP-1. The molecule has 2 structural modifications that prolong the half-life and time in circulation: the addition of a fatty acid side chain and a single amino acid substitution. Following subcutaneous administration, Saxenda molecules group together, which improves stability and delays absorption. Once released into the circulation, Saxenda binds to albumin through its fatty acid side chain, protecting it from DPP-4 degradation. These actions combine to prolong the half-life to approximately 13 hours following subcutaneous administration, allowing for once-daily dosing. Studies in animal models have shown that peripherally administered Saxenda interacts with GLP-1 receptors in the brain, including the neurons within the arcuate nucleus that are involved in appetite regulation. This causes a reduction in hunger by inhibiting AGRP-NPY neurons, and an increase in satiety due to the stimulation of POMC-CART neurons. A clinical study in people with obesity has shown that Saxenda treatment is associated with reduced hunger and increased feelings of fullness and satiety, leading to a reduction in food intake.
Good. So very nice little video just summarizing what we had spoken about. And maybe if I just highlight one point from the video is to highlight that Saxenda leads to weight loss due to affecting appetite. So it's energy intake that's affected here. It's not energy expenditure. So the therapeutic indication for Saxenda is for patients with a body mass index over 30 or body mass index of over 27 with at least one weight-related comorbidity such as dysglycemia, so diabetes, pre-diabetes, hypertension, dyslipidemia, obstructive sleep apnea. And I must say we're prescribing it a lot for patients in this category as well. The way to prescribe it, if you're familiar with Victoza, it was 0.6, 1.2, 1.8, and we generally try to go 2 weeks on each. With Saxenda, they suggest 1 week, 1 week, 1 week. So it starts at 0.6, and this time it's just a bigger, fatter, slightly different pen, and it goes up to 3 milligrams. So by week 5, we should reach 3 milligrams. But obviously, I mean, I've had patients who tolerate it very well. And within 3 weeks they want 3 milligrams. They did 3-4 days, 3-4 days. And there are others that you may get a bit of nausea, so you just give them a day or two extra here and there. It should be reassessed at 12 weeks, is my opinion. But I mean, make a clinical assessment. You also don't want to go on with the medication if it's not working. I haven't had such cases yet, but they do exist, and studies have shown that, right? And it's a very important therapeutic option. So what I'm highlighting also is that, I must be honest, with the amount of obesity we see in practice, the arrival, I'm not just saying this because I'm speaking for the molecule, the true experience in my practice is the arrival of a pharmacotherapeutic option that actually meets obesity needs. I remember 10 years ago, 12 years ago, once prescribing another weight loss medication at the time, and that weight loss medication for this patient didn't go down well because her mind went into a frenzy. She developed cardiac complications. I remember calling me to using quite expletive words to describe what a bad physician I was. I felt terrible. But the point is, we didn't have therapy that meets the need of obesity. And I think there'll be still more developments in this field. So it has made practicing a bit easier at some level, and the ability to offer patients an opportunity to have something that will help these aggressive drivers really is a lightening experience in the management of obesity. Liraglutide provides dose-dependent weight loss of about 9.2% at 56 weeks, in addition to lifestyle modification, right? And those that lose 5% or more at week 12 to 16 are called early responders, and weight loss is higher in early responders. They get up to 11.5% of weight loss. There's a wealth of global experience with liraglutide. We're comfortable with the molecule because it has been used historically in the diabetes space as well. We understand the safety and side effect profile. So that's me on the academic side of things, right? I've been asked to maybe have a discussion around a case. And so what I'll do is I'll just present a quick case here, but I've had 2 cases that were interesting today as well that maybe I'll just highlight that we can have a discussion around, and if there are any questions from the panelists, we can take it forward. But this is the typical type of patient we see in practice, sort of in their 40s or late 30s even, BMI over 30. This patient was a male, already on a statin, already on an antihypertensive. And occupation is very important to understand. This guy works as a sales consultant, so pre-COVID he would have been on his feet a lot, perhaps traveling a lot, So these guys will eat on the go and eat junk food on the way, on roads. So it's very important to be aware of that environmental aspect, right? The lifestyle work part is that he's married with 2 children, so there's a value system here that he works not just for himself, but it's for his family. All jobs today are high pressure, and I think we need to think about, and this is at the policy level, how we design work and workspaces and activity. People are using standing desks now because with COVID they're just sitting, even though they've got a high pressure job, sitting 12 hours a day His job required frequent travel, and whether that's overseas or in the car, it impacts on weight because jet lag can be an issue. Eating food in airports can be an issue. So why the need to lose weight? For him, it's about physical appearance now. Maybe the wife is saying you're not looking very healthy, or maybe as a sales consultant, he's aware that he's not being received well at the physical level. So to him, that is important, and you mustn't discount that. But what we've got to take is what is valuable to him. We must translate it into a medical thing, where you say, other than the physical appearance, which is important to change for you to feel better in society, this is also affecting your risk of heart disease. If you've got cholesterol issues, you've got hypertension, and together with stress may lead to cardiovascular fallout. So we transition what's important to the patient and make it important from a medical perspective as well. We don't just tell them about numbers and you need to get your BMI down. We say, if you don't get the BMI down, your physical appearance is certainly not going to change, but then you've got this risk of heart attack. So it all becomes coalescent in a way, and not all separate entities. So with these kinds of parameters is what we see in patients, right? And remember, the body mass index is weight in kilograms over height in meters squared. So that 181 centimeters, you use 1.81 meters squared. And there's his blood pressure. So these are classic patients. I see the total cholesterol remains high, even though he's on a statin. Blood pressure is borderline controlled. So these patients have an opportunity to improve these parameters without going on to additional therapy just by addressing the weight. And we showed you that even 10% of weight loss can put pre-diabetes into remission and bring down the risk of developing diabetes. So these are all the issues for the patients. He's not exercising enough, that needs to be encouraged. And patients need, you've got to tell them. Work management equals time management equals self-management, and self-management equals managing our minds within a 24-hour period. So I write it down on a page, just a practical example. I show my patients, there's 24 hours, there's 6 to 7 hours you've got to sleep. So you subtract that, you're left with about 17, 18 hours. So I said, now you take that 18 hours and you say, like, you need 1 hour for exercise, so you're left with 17. Then you need 1 hour, 1.5 hours for eating, perhaps cooking if you're alone, wife's not cooking or whatever it is. Then you need time at work. You've got to set your time at work at 7 hours or 8 hours, and in that work time, you need your breaks, you need your eating correctly. So even if you do it that way, there's still about 7 or 6 hours that you've got available, and that you want to proportion to looking at stress, doing some extra work, spending time with the kids. So if you properly time manage, there is a lot of time to do stuff in the day. We mustn't assume that patients know how to do that. You also got to show them sometimes how much of time goes into energy dissipation with non-essential things, like browsing the internet and social media. So these are the practical tips to help patients. And when you talk to them like this, you get a lot of nice buy-in from them that, hey, I'm being coached here, I understand better, nobody's talked to me like that before. And then when you bring the pharmacotherapy in later, and you say, now this is going to assist you further, you get better buy-in. So it's just important to be aware in these kinds of cases that there are a lot of mental, mechanical, metabolic, and other financial factors that need to be assessed. And it's beyond the scope of this talk to go into all the details. In the near future, I'll be running through our practice on life management courses, and we'll advertise it on our website, where we'll be talking about mental stuff on the monetary factors. And then this year, we got a lot of attention on this, and we get seminars on this stuff, Important to just ask him about the lower abdominal pain, make sure there's nothing going on there, and investigate it if necessary. Right. So ultimately, this is the type of patient where after 1 or 2 visits, we get them into the dietary interventions, we get them going into physical activity. We don't expect people to run the comrades overnight. What we want them to do is to understand that energy needs to be expended. And the only way to do it is through movement, and movement is voluntary for the patient through managing the mind. I need to desire to exercise. And you link that desire to an ultimate purpose or life goal. You see? Saxenda does come with an online coaching program. And I think that's important. Coaching is not telling people what to do. It's being available to guide them when the mind becomes weak and wants to fall. So a very simple way to remember this is remember gravity. To fall from a height, you don't need to make any effort. Gravity pulls us down. It seems similar with human behavior and mind, that to do the wrong things is automatic. Eating junk, you don't have to get an education on eating junk. It comes automatically. But to rise, to go against gravity, you need effort, you need wings, or you need jet propulsion. So for a human to rise against our lower nature, we need education, we need assistance. When we start falling, we need someone to prop us up. So that's the lifestyle coaching. Coaching is to constantly not just push people up, but be available when they're falling while the self-effort keeps working. They may need sleep therapy. You need to look at obstructive sleep apnea, look at the need for positive airway pressure, masks, etc., and then the pharmacotherapy as well. And we introduce pharmacotherapy very nicely. First I talk to the patients about benefits of Saxenda or liraglutide 3 milligrams. I always tell them straight up. I tell them this is the positives, it's been studied, and we've got these opportunities with the drug. And then I say, look, every drug has a downside. And you may feel a bit nauseous, a percentage of patients do, but even those that do get the side effects, a large percentage develop tolerance. And even then, they've assisted you by designing it in a way that you can titrate it to manage the initial side effects, I preempt the Google reading, so patients will ask about thyroid cancer, and I put those messages to bed. Remember, liraglutide does not cause thyroid cancer. It was an association of a particular type of C-cell cancer in mice. And then when it was studied, we looked at it, and remember, these C-cells don't exist in human beings. It may be an issue in a particular form of medullary thyroid cancer, in a rare genetic condition called multiple endocrine neoplasia, which is a strong family history of it, and they have other endocrinopathies as well. So unless the patient has that, the thyroid cancer issue is not a major issue at all, and you reassure them beforehand. So I tell them, I know you're going to Google, I know you're going to see the words thyroid cancer. I want you to not worry about it because we are aware of it. We would not be prescribing this if it was a risk to you in this situation. So when you preempt things, you get less callbacks and less anxiety, you see. So I've given you some tips on initiating obesity conversation, and show patients slides sometimes, show them the significant weight loss, and always emphasize that it's going to be with diet and exercise. And I give them the details of the dietitian, and I get them in contact with Saxenda Care, and you got to be proactive with this, right? Collaborative effort means sometimes needing psychologists and even psychiatrists as well. And don't be afraid to bring that. The discussion around needing a psychologist is often a sensitive one in my experience. Patients think, oh, I got it figured out, I know what to do. So I often use stories to tell them, look, I've had patients who are very highly sort of in high structures of business and high functioning people, successful in life, but we all have our blind spots. And remember, using the word we, I don't say they, makes you more human because you're saying, I also have blind spots and I also need to evolve where the mind is concerned. And there's nothing wrong with asking for guidance at our blind spots and weaknesses. If you want to learn to play the violin, you go to a violin teacher. If we need to learn to manage the mind, we need to go to an expert on that sort of area. Let's say you choose someone that's receptive to you in terms of life coaching or psychologist. And generally the patient will say, you know what, that sounds good, let me do that, So the Patient Support Program, a quick summary of it. There are a couple of things here. First of all, there's a Truth About Weight website, which is a digital platform. Hello, sorry. Okay, I suppose that was a mistake. I hope everyone can still hear me. What I was saying is that there's a website called Truth About Weight, which is available to the general public, and it has a lot of information about obesity, general information, not product information, and this is there to help empower people through education. You see what you know. If you know better, you can see the issues. This virtual coaching platform comes along with liraglutide, so you prescribe it to a patient, they qualify to register for this sort of free 40-week virtual coaching platform. Our patients have had very good report backs on it so far, and I'm sure the company can tell you more about it if you need more detail. This along with tele-coaching with obesity patient educators which has been provided to give that personal touch. I think that's very important, right? So I think these are very useful sort of measures. But that concludes my part of me just talking. I think we're going to invite some discussion or questions if there are any. I can't see the chat group right now to see if there are questions. I'll just leave you with this thought here. For those of you that know my lectures, I mean, I'm a great advocate for lifestyle, philosophy of life, but I am very glad that we have physical interventions that can help patients now. I was with some cardiologists, Professor Eric Kluk this weekend, and Professor Brian Rayner, and even the cardiologists, we're having this discussion around how we need to rethink organically thinking about obesity as a root cause of issues. And we had such a nice conversation that just yesterday, the cardiologist WhatsApped me to say, look, I have a patient in the public sector that's very obese. He doesn't have medical aid. He can fund this medication on his own. His BMI is about 36. How do I get in contact with someone that can help me with Saxenda prescription and Saxenda care? So this was a cardiologist in a public hospital clinic calling me to say, I see the benefit of this. So I think there's a lot of room here that we can help our patients with. Just be aware of that. But remember, there's a person in that body, and they're looking for something better in a very difficult world. So let's assist them where we can in an objective way. Thank you very much for your attention. I'm going to stop the share part and let's see if I can do that here. And then invite some questions. Rebecca, I'll hand over to you.
Dr. Ruder, thank you so much. Your presentation has been very valuable in defining obesity as a chronic disease and also just outlining the complexity and the multiple factors that contribute to the disease. I will now open the floor to questions. So there are individuals who are attending the meeting in person. If you would like to pose a question, please do so if you are attending the meeting face-to-face. And if you are on the Teams platform, also raise your hand and you will be afforded the opportunity to raise your question to Dr. Ruder. The people in Port Elizabeth.